Welcome to the webinar on craniocervical neuroanatomy and its clinical implications. As physiotherapists, we work with patients who suffer from upper neck pain and discomfort. If we could better understand the structures that are pain sensitive and the way in which the nociceptive information is transmitted to the central nervous system, we could provide our patients with quite better healthcare. On that note, I, Dr. Zubin Bhausar, put forward you this presentation. Topics for presentation, aims and goals, what we want to accomplish with this presentation, general introduction to cervical spine neuroanatomy, what are the innervation of craniocervical region, important notes, which are key points and summary. The aim and goals of this presentation is to make complex neuroanatomy of cervical region simple and easy to understand, to know the anatomical relationship between various neural structures and cervical vertebra, to identify and know the pain generators in the craniocervical region, to implement this knowledge in clinical diagnosis and treatment of cervical spine disorders. Contents of this presentation includes general introduction, relationship of the neuroaxis and cervical spine neural elements, innervation, that is the pain generators and pain patterns of craniocervical region, nerves of the cervical region, neuroanatomy of the cervical intervertebral foramen, and the summary. General introduction. Migraine has estimated global prevalence of 14.7%. That's around 1% in every 7 people. Approximately 47% of global population suffers from headache, and out of which 15 to 20% of those headaches are cervicogenic in nature. Estimated proportions of time spent with migraine and cervicogenic headaches, that is the actually experiencing the attack during an average person's life, is 5.3%. Studies have revealed that migraine is a disorder that almost certainly has genetic basis. However, the pain conduction pathway remains that of craniocervical region. The craniocervical region houses one of the most densely innervated tissue structures. Various studies reveal that irritation or dysfunction of any structures innervated by the 3 upper cervical nerves can potentially generate local pain or referred pain into head, face, occipital, and suboccipital region. Somatic structures of craniocervical spine are innervated by dorsal and ventral branches of the first 3 cervical spinal nerve. Let's study what are the pain generators and pain patterns of cervical and cranial region. We will then discuss how knowledge of these different pathways of pain referrer can assist in differential diagnosis of head, neck, and facial pain. In order to be classified the types of pain experienced by the patient, knowledge of innervation and pain referral patterns and the upper cervical peripheral nerve pathways is essential. Craniocervical pain can be classified into peripheral nociceptive pain, which is local pain due to irritation of nociceptors within local somatic tissues of the craniocervical region, as well as referred pain from somatic structures within the craniocervical spine, and secondly, into peripheral neurogenic pain, which is referred pain from irritation of craniocervical neural tissues, upper cervical spinal nerve roots or trunks. Now, before we dive deep to fish the pain, let's first understand about the orientation of nervous system in cervical region. On your left hand side in the X-ray, please kindly pay attention to the black pillar like shadow. That is that of the cervical cord inside the vertebral foramen. We will understand the orientation of the nervous system in cervical vertebral column. We will obtain answers to how the nervous system is held in the cervical vertebral column. Also, What holds the suspended spinal cord in the cervical spine vertebral column? The spinal cord has its first meningeal layer, that is the pia mater, which is the innermost laminating layer enveloping the entire spinal cord. The third outermost layer of the meningeal layer is dura mater, which is in continuation as the outer layer of spinal nerves. In between the pia mater and dura mater is the arachnoid mater, which has connective tissue form of spiral web formation. The denticulate ligaments, which are triangular in shape, attach the outermost dura mater with the innermost pia mater. Denticulate ligaments acts as an anchor point for the spinal cord inside the dura mater sleeve. The denticulate ligaments also separates the dorsal and ventral rootlets. Now, the space between the dura mater and the bony ring of the intervertebral foramen is known as the epidural space, and this space is filled with adipose tissues and blood vessels. Please note that the entire spinal cord is freely suspended in a sac-like structure. The pia mater is attached with dura mater by denticulate ligaments. The outermost dura mater or the spinal dural sheet is not directly glued with the vertebral bone, but instead the adipose tissue buffer the space, providing cushion against the hard bony parts surrounding the entire spinal cord. This arrangement makes possible the gliding of the entire spinal cord in the vertebral column. Also, the meninges are in continuation as an outer layer of the spinal nerves. The point to be noted over here is that the innervation of these nerves with the respective muscles is known as myotomes. Now, the myotomes, they anchor the spinal cord, providing the grip inside the vertebral canal. Spinal dura mater is also anchored by suboccipital muscles. The upper cervical spinal cord is directly attached to the circumference of the foramen magnum. It is also attached to the second and third cervical vertebra, and by fibrous slips, it is also attached to posterior longitudinal ligament. Please go through our previous presentation on cervical spine anatomy to explore more about those structures. The myodural bridges. The myodural bridges are connective tissue between the suboccipital muscles and the cervical spine dura mater. The myodural bridges helps in anchoring the spinal cord within the vertebral foramen. This arrangement and their detailed function is discussed in separate presentation. As you can see over here, the suboccipital muscles, rectus capitis posterior major and rectus capitis posterior minor, they are connected with the spinal cord with an attachment on the outer meningeal, that is the spinal dura mater. Small a and the star over here, this is actually a representation of the myodural bridges with rectus capitis posterior major with the spinal dura mater. Here, the rectus capitis posterior minor with that of the spinal dura mater. These are the myodural bridges. Key points. The upper cervical cord is directly attached to the circumference of the foramen magnum, as well as to second and third cervical vertebra. It is also attached to posterior longitudinal ligament by fibrous slip. Suboccipital muscles are attached with spinal dura and they exert tensional pull on the cervical cord. Spinal dura sheet is not directly glued with the vertebral bone, but instead the adipose tissues buffer the space, providing cushion against the hard bony parts surrounding the entire spinal cord. The myotomes also anchor the cervical spinal cord, providing the grip inside the vertebral canal. We will now discuss about the neural elements and we will obtain answers of the following questions. What are the neural elements in craniocervical region and how the spinal nerves are formed? These are the neural elements of the cervical spine. From spinal cord, the rootlets emerge out. The rootlets, ventral and dorsal rootlets, they join together to form the roots, which are again ventral and dorsal. Now, each ventral and dorsal roots, they both join together to form mixed spinal nerve. And mixed spinal nerve, it bifurcates into dorsal and ventral ramus. Now, especially on the dorsal side of the mixed spinal nerve, in the dorsal ramus, there is dorsal root ganglion. The rootlets include dorsal and ventral rootlets, which are separated by denticulate ligaments. On your screen over here, please pay kind attention. This is the dissected portion of the spinal cord from the dorsal view. Now, as you can see, those are the rootlets. The dorsal rootlets are shown over here, and ventral rootlets are not visible as they lie on the ventral side. Now, the important point is that the denticulate ligaments, which are triangular in shape, they separate the dorsal and ventral rootlets. So, if those are the rootlets, the denticulate ligaments will lie in such a fashion which would separate the ventral and the dorsal rootlets. We now move on to anatomy of mixed spinal nerve. Anatomy of mixed spinal nerve as shown in figure over here. The dorsal and ventral rootlets, they give rise to dorsal and ventral roots. Now, dorsal and ventral roots join together intervertebral foramen to form mixed spinal nerve. The dorsal and ventral roots unite within the region of the IVF to form mixed spinal nerve. The mixed spinal nerve is short and almost leaves immediately, and it divides into dorsal and ventral ramus, that is the posterior primary division, and the ventral ramus, that is the anterior primary division. As you can see over here, these are the rootlets. The ventral rootlets and the dorsal rootlets. The rootlets, they join together, they emerge from the spinal cord. They join together to form the dorsal and ventral roots. On the dorsal side, there is a dorsal root ganglion, which is demonstrated over here. The superior view of atypical cervical vertebra showing the relationship with the neural elements. Notice the dorsal and ventral rootlets, the mixed spinal nerve, posterior and anterior primary divisions, that are the dorsal and ventral rami. The posterior primary division can be seen divided into medial and lateral branch. The recurrent meningeal nerve can be seen entering the intervertebral foramen. The fibers arising from the middle cervical ganglion and the gray communicating ramus are also shown over here, communicating with the recurrent meningeal nerve. Now notice that these fibers supply the anterior and lateral aspect of the intervertebral disc. These are the general rules. Denticulate ligaments separate the dorsal and ventral rootlets. Mixed spinal nerve is located in the IVF. The spinal ganglion is only present in the dorsal root, and dorsal ramus are smaller than ventral ramus. Dorsal ramus lie in quick proximity with the facets. The dorsal ramus innervate the deep intrinsic muscles. The ventral ramus, they innervate the extrinsic muscles. We will discuss about those muscles in kinesiology presentation. With having understood the neural elements, let's have a look at the cervical nerves. We will obtain answers to the following questions. What are the cervical nerves? How they are formed? And its importance from the clinical perspective. There are 8 cervical nerves, each exiting the vertebra above their correspondingly numbered vertebra, with exception to the 8th cervical nerve. which lives through the foramen formed between C7 and T1. The exiting nerve passes above the correspondingly numbered pedicle, and this differs from the thoracic and lumbar spine. The nerve exiting here passes below the corresponding number pedicle. Each mid-spinal nerve divides into ventral and dorsal ramus. Now first have a look at the ventral ramus. Let's see what structures does the ventral ramus innervate and how they are important from a clinical perspective. Key points to remember: ventral ramus leaves this mixed spinal nerve. It passes posterior to the vertebral artery, forms the cervical and brachial plexus. They innervate the intrinsic muscles of the cervical spine as a general rule, but there are few exceptions. The C1 ventral ramus also innervates the atlanto-occipital joint. The C2 ventral ramus innervates the medial and lateral atlanto-axial joint, the anterior longitudinal ligament, and it also innervates the upper extremity by its participation in formation of brachial plexus. Let's have a quick look at how the cervical plexus is formed and how it is important clinically. Cervical plexus is formed by ventral rami of the upper four cervical nerves, which consist of deep muscular branches which supply the muscles and superficial branches which supply the skin. The deep branches of the cervical plexus innervates the prevertebral muscles, which are the craniocervical flexors, as well as the scalenes, the levator scapulae, the trapezius, and the sternocleidomastoid. We will study these muscles in kinesiology presentation. The ventral ramus of C1 and C2 spinal nerves provides the sensory supply to atlanto-occipital joint, atlanto-axial joint, the facet joints, respectively. The superficial cutaneous branch of the cervical plexus forms the following nerves. The lesser occipital nerve, formed by the branches of ventral ramus of C2, it supplies to the skin of the neck and scalp posterior to the ear. This portion. The greater auricular nerve, that is formed by the branches of C2 and C3 ventral rami, which it supplies to the skin around the ear and mastoid area. The transverse cervical nerve, which is formed by the branches of the C2 and C3 ventral rami. The superficial cutaneous branches of the cervical plexus, which form the following nerves. The lesser occipital nerve, formed from a branch of the C2 ventral ramus. It supplies to the skin of the neck and scalp posterior to the ear, as shown in the figure. The greater auricular nerve, formed by the branches of C2 and C3 ventral ramus. It supplies the skin around the ear and mastoid process area. The transverse cervical nerve, which is formed by the branches of C2 and C3 ventral rami, it supplies the skin on the lateral and anterior part of the neck, this portion over here, and the supraclavicular nerve, that is formed by the branches of C3 and C4 ventral rami. It divides into three nerves, medial, intermediate, and lateral, and supplies the skin over the sternocleidomastoid, sternoclavicular joint, upper chest wall, acromion process, and posterior part of the shoulder. Now this nerve is important from the clinical perspective because patients having head and neck pain also complain of pain radiating to the shoulder area, especially the posterior portion in front of the clavicle up to the sternocleidomastoid. Let's have a look at the recurrent meningeal nerve and its clinical anatomy. The sinovertebral nerves are the branches from the ventral rami which re-enter to the intervertebral foramen and ascend or descend as many as 4 vertebral segments within the vertebral canal. The sinovertebral nerve originates from ventral ramus and receives contributions from gray communicating ramus and sympathetic nerves. There are more than one recurrent meningeal nerve present at each level and supplies posterior aspect of the intervertebral disc, posterior longitudinal ligament, anterior spinal dura mater, posterior vertebral bodies, the oncovertebral joint. Key points to remember: the C7 ventral ramus is the largest, followed by C8 and C6. They are the smallest as compared to C7. Now, C5 is the smallest amongst the C5, C6, C8, and C7. Let's have a look at the DRGs. The cell bodies of all efferent nerve fibers are located in the dorsal root ganglia, also known as the spinal ganglion. The C2 dorsal root ganglion is the only ganglion which is normally located outside the spinal dura mater. The C2 dorsal root ganglion is located posterior and medial to the lateral atlantoaxial joint. It contains the cell bodies of sensory fibers innervating the medial atlantoaxial joint. The lateral atlantoaxial joint, part of portion of neck and scalp, and the posterior occipital region, as well as up to the coronal area covering the coronal sutures of the skull. Now, with such an innervation, the irritation of this structure can create symptoms ranging from suboccipital headaches to migraines. Now, with having understood the ventral rami and their distribution, we now move on to the dorsal rami and their distribution. The dorsal rami innervates the deep back muscles. It has the motor innervation to transversospinalis, erector spinae, splenius capitis, and splenius cervicis muscles. The sensory innervation to the skin of the neck. The dorsal rami of C6, C7, and C8 usually do not have cutaneous branches. The suboccipital nerve. The dorsal ramus of first cervical nerve is called the suboccipital nerve. Very famous in clinical practice. It exits the spinal cord between the occiput and the posterior arch of C1. It then enters the suboccipital triangle where it supplies the suboccipital muscles. Now, any changes of the suboccipital muscles can potentially affect suboccipital nerve, giving rise to the peripheral neuropathy condition known as the suboccipital neuralgia. The C2 spinal nerve branches into dorsal and ventral ramus posterior to the lateral atlantoaxial joint. The C2 dorsal loops superiorly around the oblique capitis inferior muscle and then divides into medial, lateral, superior communicating, inferior communicating, and a branch to the oblique capitis inferior. The lateral branch of the dorsal ramus of C2 helps to supply the motor innervation to the longus capitis, splenius capitis, and semispinalis capitis muscles. The greater occipital nerve C2. The medial branch of C2 dorsal ramus is called the greater occipital nerve, also known as GON. It emerges between the atlas and the axis. It passes through the atlantoaxial joint capsule and ascends to innervate the skin over the posterior part of the scalp as far as forward up to the vertex of the skull. It is closely related to the posterior aspect of the atlantoaxial joint, and as a result, it is susceptible to any changes occurring at this joint. Owing to its large range of motion, the atlantoaxial joint is particularly more prone to osteoarthritic changes, such as osteophytic growths. Now, those osteophyte growths or the spurs may irritate the greater occipital nerve and result in peripheral neuropathy, frequently referred to as greater occipital neuralgia. Additionally, the C1-C2 level is commonly affected by rheumatic arthritis and may become unstable as a result. In this situation, the greater occipital nerve may become a source of occipital pain. Also, this nerve receives communicating branch from the third occipital nerve before piercing the large semispinalis capitis muscle. The greater occipital nerve is accompanied by occipital artery. It reaches the scalp by passing through a protective aponeurotic sling. This sling is associated with insertion of the trapezius and sternocleidomastoid muscles onto the superior nuchal line. The aponeurotic sling actually prevents the greater occipital nerve from being compressed during contraction of these muscles. After passage through the sling, the greater occipital nerve courses superiorly and then divides into several terminal branches. These branches provide a good broad area of sensory innervation extending from the occipital region medially to the region superior to the mastoid process and posteriorly to the ear laterally. Superiorly, they supply sensory innervation to the scalp from the region of the posterior occiput as far as to the skull's coronal suture. The terminal branches of the greater occipital nerve also provide sensory branches to the occipital and transverse facial arteries. Causes of irritation of the nerve or the ganglion include direct trauma to the posterior occiput as well as entrapment between the traumatized or hypertonic cervical muscles, particularly the semispinal scaputus. Also, hyperextension injuries to the neck, especially during rotation, can also compress the C2 ganglion between the posterior arch of the atlas and the lamina of the axis. Now, restriction within the facial sheath can also occur with the changes in the hypertonic sternocleidomastoid muscle and trapezius, and this restriction may interfere with the gliding mechanism of the nerve within the aponeurotic sling, and which may lead to mechanical irritation or compression of the nerve and may reproduce the symptoms associated with irritation of greater occipital nerve. Now let's move on to the C3 spinal nerve. The superficial segment of medial branch of C3 dorsal ramus is the third occipital nerve. Key points for the third occipital nerve. The third occipital nerve, the dorsal ramus of C3, divides into several branches. The superficial medial branch is called the third occipital nerve. It passes posteriorly around the articular pillar of C3. It innervates the C2 C3 facet joint and supplies the skin over the suboccipital region. Close association of the third occipital nerve with C3 and C2 facet joint, it means that any dysfunction at this joint has potential to irritate the nerve and generate pain within its cutaneous field of distribution. The third occipital nerve has also been implicated in cervicogenic headache by many authors. This is of importance: scalp innervation, the greater occipital nerve, the third occipital nerve, and the lesser occipital nerve, and the innervation of the scalp up to the scalp. The greater occipital nerve has innervation up to the vertex, that is the coronal suture of the skull. It majorly covers this whole entire area over here. But the key point over here is that the symptoms, they originate above the external occipital protuberance, while the third occipital nerve has got distribution below the external occipital protuberance in the suboccipital region. Many authors also refer to this nerve as it supplies the sensory distribution up to the collar portion, where our collar lies. The third one, that is the lesser occipital nerve, it has distribution into the scalp, posterior lateral portion of the ear, behind the ear. Let's discuss the fate of spinal nerves C4 to C8. The C4 through C8 take exit through the respective IVF. That is, the C4 through the C3 C4 IVF, that is the intervertebral foramen, and C8 through C7 T1 intervertebral foramen. Crevilliar plexus. What is the anatomy of this plexus? Now, this is a summary done by few authors. They have found interneural connections between the dorsal rami of the upper cervical nerves. Now, in the studies, 86.7 of the cadavers showed it, which primarily composed of sensory fibers, but also occasionally motor fibers too. For C1, a communicating loop joined the medial branches of C2. In some cases, this loop also pierced through the oblique capitis inferior muscle before joining C2. Also, a communicating loop joined the medial branches of the dorsal rami between the C2 and C3. They also found a communicating loop joining the middle branches of dorsal rami of C3 and C4. While the important point to be noted over here that they didn't find any communicating branches or loops between the dorsal rami of cervical nerves 5 to C8. Now the important point over here is that this is a very complex innervation, complex plexus between dorsal rami C2, C3 and C4. They are internally connected, and this makes it quite difficult to identify the single root cause of their symptoms. Now the summary of the structures supplied by the dorsal and ventral rami. Please have a look. These are the summary of the ventral rami of C1 to C3. It supplies to the cranio-cervical flexors, the scalenes, levator scapulae, trapezius. It has sensory supply to atlanto-occipital joint, atlantoaxial joint, transverse ligament, the alar ligament, pectoral membrane, the upper cervical dura mater, and skin around the ear, and anterior lateral part of the neck. The ventral rami supplies to this portion. Now the dorsal rami of C1 to C3 supplies the suboccipital muscles, the posterior neck muscles, skin over craniocervical spine, the occiput, and the ligament nuchae. Now we move on to the neuroanatomy of cervical intervertebral foramen. Where exactly does the neural elements that we have just discussed lie in the IVF? Also, what is the relationship between the dorsal root ganglia, the vertebral artery, the ventral root in the IVF? As you can see, the foramen is bounded by pedicles superiorly, inferiorly, posteriorly by the facet joints, and anteriorly by the oncovertebral joints and the intervertebral disc. The foramen of transverse process of vertebral artery for the vertebral artery lies in the floor of the IVF. If we divide this intervertebral foramen into three levels, the upper first portion, we can see that it contains fat, vein, and anterior epidural space. The middle portion, the middle level, we can see that it contains dorsal and ventral roots. Now, important thing over here is that in the below third level, there is dorsal root ganglion. The dorsal root ganglion, that is this thickening over here, it lies in the lower third of the IVF, intervertebral foramen. The space above it is occupied by vertebral artery, fat, and the ventral ramus. Now this arrangement makes the dorsal root ganglion and ventral nerve roots vulnerable to compression, as well as the dorsal root ganglion is more prone for the impingement inside the IVF because of the osteophyte formation and because of the degeneration of the oncovertebral joints, that is this peak over process, and the facet joints lies behind the dorsal root ganglion. This portion over here, this is the facet joint, cervical facet joint, and this is the oncovertebral joint. Now, because of the degenerative process, because of the degeneration in the spine, the spurs, they irritate the dorsal root ganglion. Also, in cervical spine region, the prolapse of intervertebral disc can also compress the dorsal root ganglion, and because of this entrapment at this level, at this site of the dorsal root ganglion, there are many symptoms which patient experiences. All the manual therapy techniques for the facet joint release or the mobilization of the cervical spine, they are directed for the opening of the space at this intervertebral foramen. So it is of prime importance for a physiotherapist to understand exactly where does the dorsal root ganglion lie inside the IVF to modify or to adjust the vectors that we will be discussing in separate presentation on treatment. For time being, just pay attention to here and just have a look at the neuroanatomy of the orientation of the neural structures in IVF. The facets, the colored portion over here on your screen, they demonstrate these are the sites of peripheral pain patterns when the particular facets are involved with pathology. For example, the green portion over here, the lateral aspect of the suboccipital region, the C2, C3 facet joint may cause the referral pattern of the pain. Below it, the lateral aspect of the neck shown over here in the blue portion, it refers to the C4, C5. Now on the posterior shoulder and the subscapular portion, posterior portion of the scapula, C6, C7. Now at the area where the trapezius muscles lie or the levator scapulae muscles lie, the upper trapezius portion on this portion is from the C5, C6. So why this is important to know, because it may mimic the symptoms of trapezitis, but actually the original cause of pain or the source of pain may be from C5, C6. Specifically, if you notice over here, the orange spot over here denoted by AA refers to the pain pattern referring from the atlantoaxial facet. So in many patients, when you have unilateral headache, precise location of AA, you can suspect the cause of pathology from the atlantoaxial joint. The contribution from the sympathetic nervous system in the innervation of the cervical region. The sympathetic trunk key points. The cervical sympathetic chain lies anterior to the longus capitis muscle. There are three ganglions: superior, which is located inferior to the suboccipital and anterior to the transverse process of C2, C3, the middle one, which is located anterior to the transverse process of C6. The inferior ganglion, it unites with the thoracic ganglion and forms the cervicothoracic, that is also known as stellate ganglion, and which lies inferior to the transverse process of C7. It innervates the intervertebral disc by sinovertebral nerve. It also innervates the vertebral artery by complex plexus for the vertebral plexus nerve. Because of these complex innervations with the artery and with the sinovertebral nerve, it may be a potential source of headache and cervical pain. Sympathetic dysfunctions result into cervical spine pathologies. Anatomy of the sympathetic trunk and its relationship with the cervical vertebrae and other structures. The superior ganglion is by far the largest, and it is positioned inferior to the occiput and the anterior to the transverse process of C2 and C3. Like according to many sources, the middle cervical ganglion in the sympathetic chain is not always present, but when it is present, it lies anterior to the transverse process of C6. Inferior ganglion unites with the first thoracic ganglion to form cervicothoracic or the stellate ganglion, which lies inferior to the transverse process of C7. So we now move on towards the end of the presentation, and these are the conclusion. The cervical portion is jam-packed with nerves and it interconnected plexus. Many of the structures have dual sensory supply. Facets, intervertebral disc can be source of headache and pain. Now, the disc itself also receives innervation from autonomic nervous system. And dorsal root ganglions and the ventral root are closely situated within the IVF in close proximity. Thus, the cervical portion should be handled with care. And there may be a number of sources responsible for the symptoms with patient experience, ranging from simple headache to migraines to complex symptoms such as nausea, vomiting, and many other unexplainable symptoms such as heaviness, pulling, irritation, pinching inside the scalp, inside the ear, behind the ear, inside the eyes. So these all are the symptoms associated with pathologies involved with cervical spine, especially the upper cervical spine segment. We hereby end the presentation. With completion of this presentation, please view the kinesiology presentation to know more about the movements of the cervical spine and the muscles acting on it. Also, presentation on the cervical spine disorder and differential diagnosis. If you have not attended our previous presentations on cervical spine anatomy, do go through the website www.physiosports.in for more details. Thank you for your attention and be safe. Good night. God bless you all.